All right, should we get started? I'm Colin Huntley. I'm from Thomas Jefferson University in Philadelphia, and I just want to thank Dr. Gupta and Sarah Lynn Buck for putting all this together. So let me just adjust some of this. We'll talk about upper airway stimulation for obstructive sleep apnea today. I'm just navigating this a bit so I can see if anyone has questions. Please interrupt me or reach out, and we will make this more discussionary as we move along here. So I have some grant funding from Inspire Medical. That's my only relevant disclosure related to this topic. And we'll start with just a background of OSA. So as we all know, it's recurrent upper airway obstruction that occurs during sleep. And it can happen at a number of different levels of the upper airway. Typically, it can happen at multiple levels. And one of the ways we categorize this is through this VOTE classification. I won't get into this too much, but this is typically used for drug-induced sleep endoscopy to classify the location and the character of the anatomic obstruction. VOTE stands for velum, so that's the area right behind the palate, the oropharynx, and what we'll see is lateral oropharyngeal obstruction, either from tonsillar hypertrophy or from the lateral walls of the oropharynx collapsing inward. You can see tongue-based obstruction related to either lingual tonsillar hypertrophy or posterior collapse of the tongue base. And then the epiglottis can be obstructed as well. So with each of these areas of obstruction, you see limitation of airflow periodically and repetitively throughout the course of the night. This alters ventilation, meaning it alters the level of CO2 in the bloodstream, it elevates, and then it disrupts the sleep architecture, so causing multiple arousals or mini awakenings throughout the course of the night, leading to some of the daytime symptoms, and then also causes some sympathetic stimulation or sympathetic nervous system stimulation. And this sympathetic stimulation is what causes all of the cardiovascular issues that we see long term. So elevated blood pressure, irregular heartbeat, and different different types of cardiac arrhythmia, with AFib being the most common, stroke risk, coronary artery disease risk, and maybe some issues with metabolic syndrome. Oops. So I like to think about these areas of obstructions as valves or different areas within the airway that are obstructing, and trying to somewhat simplify the type of obstruction and then how are we going to fix it. At the level of velum, so I'll start from the top down. At the level of the velum, I like to think of it as a flapper valve. So if anyone's ever taken the lid off of a toilet and you look down, you see this valve here that's connected by the chain to the lever, and it flaps open and closed to let water in. So when you lift the lever, it lifts the chain, which lifts the flapper valve open, allowing water in. Similar concept at the level of the velum. So that palate is supposed to close in a either front to back or side to side motion, similar to a flapper valve. And when we take a breath in, it's supposed to open. And when we speak and when we swallow, it's supposed to close to limit velopharyngeal insufficiency and also help to help with the intonation of our voice. I'm just going to stop sharing for a second. Okay. So anyway, so it's supposed to, like I said, open when we take a breath and close with eating or speaking. In sleep apnea at night, you see closure of this valve or narrowing of this area, limiting airflow into the lungs, which is causing one site of obstruction that we see fairly commonly. The other area we see is the back of the tongue base, or the tongue in general. This has more of a ball valve type of collapse to it. So we all know about ball valving in airway obstruction lower down in the lung, so a foreign body within one of the bronchi having a ball valve effect. Same type of thing happens at the tongue base. in someone without obstructive sleep apnea or sleep disordered breathing, there is some intrinsic tone to the genioglossus muscle, and you'll see some stimulation of that muscle during the respiratory cycle to stiffen the tongue and pull it forward a little bit and move that ball valve out of the obstructive position to help to open up the airway to some degree. This is what limits obstructive events in the quote unquote normal population who does not have a history of sleep disordered breathing. In those patients with sleep apnea, you see that ball valve falling backward and causing some obstruction of the airway. And the last area to think about is the pharynx itself. And I know I mentioned the epiglottis. The epiglottis, I think of, it typically is in association with the tongue base. There can be isolated epiglottic obstruction. However, that's not something we see very commonly. You think of the pharynx as it's a muscular tube, but in obstructive sleep apnea patients, it typically has floppy walls to it. The pharyngeal constrictor muscles do have some intrinsic tone at night. Specifically, the innermost layer of those myocytes will maintain some intrinsic tone that will stiffen that tube and limit the collapse. There's also something called tracheal tug that you see. So as there's increased volumes in the lungs, there is some weight to that pulls down on the trachea. And in pulling down on the trachea, pulls the pharynx, slightly elongates the pharynx, and stiffens the tube. The corollary thing, think about a floppy hose and something that does not have much tone or much structure to the walls, you're going to see a lot of collapse and limiting of that lumen. Whereas a hose or tubing that's made out of metal has much more structure to it. Also, if you picture this and you lengthen it out, it's going to stiffen the walls of that hose, also limiting some of the collapse. So we know that sleep apnea impacts a large proportion of the population. This is a meta-analysis that I pulled, and you see folks with at least mild sleep apnea can impact almost up to 40% of the population. We see this more in men than in women, and we see it more as people get older. With age, you see less muscle tone within the pharynx and the tongue base. Typically, people tend to gain some weight as they get older. And then when we look at clinically significant sleep apnea, meaning moderate and severe disease, that can impact up to about 20% of the general population, again, increasing as the population ages and also increases in size. So with this obesity epidemic, we're seeing more and more of this disease. I say clinically significant sleep apnea, meaning moderate and severe disease, because we know that there's a number of comorbidities obstructive sleep apnea can impact. Hypertension, some of the things we mentioned already, hypertension, cardiac arrhythmia, coronary artery disease, stroke, metabolic syndrome, so on and so forth. You see that risk increased in moderate and severe apnea. You don't necessarily see the same increase in risk in mild sleep apnea. So mild sleep apnea patients without comorbidities already and who are not symptomatic don't necessarily require treatment or aggressive treatment for that matter. With that being said, every diagnosis, mild, moderate, severe, can have a significant impact on quality of life, meaning sleep quality, frequent awakenings at night, daytime fatigue, and then the subsequent impact on work productivity and car accidents is another category that gets a lot of press. So positive pressure therapy is our common first modality of treatment. This can be either CPAP, which is continuous positive airway pressure, and that means that it's one pressure through both the inspiratory and expiratory phase of the airflow cycle or the breathing cycle. This can be an auto CPAP, meaning that pressure fluctuates throughout the course of the night, depending on how much apnea there is or how much airway obstruction there is. Or it can be set pressure, where you set it to a specific centimeter of water, 9 centimeters of water, 10 centimeters of water, whatever is selected, and it stays at that pressure all night. BiPAP is my level, meaning high inspiratory pressure, low expiratory pressure. In terms of obstructive sleep apnea in isolation, this can be more comfortable for some patients. It's also used in patients who have other pulmonary comorbidities to help with ventilation. So there's a number of different masks, and the patients who tolerate this well, it works very well for. We know that it controls their symptoms and has significant impact on comorbidities. And these are just some examples of masks. So you have a full face mask, just a mask that just goes around the nose, and a nasal pillow mask. These are three of the general designs, and you're trying to fit for comfort, limiting leak, and also tolerability. Like I said, it has CPAP. We know has significant impact on quality of life, daytime fatigue, mood disorders, cardiac arrhythmia. The reason I have cardiovascular outcomes and metabolic outcomes italicized and in red is the data is not definitive to say CPAP offers drastic improvement in these outcomes. We know that it does impact blood pressure. With that being said, it impacts blood pressure between somewhere between 4 and 10 millimeters of mercury, both systolic and diastolic. I always ask the question to our medical colleagues if this is clinically significant. As an otolaryngologist, frankly, I'm not sure, but we know that it drops blood pressure, but is it a clinically significant drop? I'm not sure. There is some benefit for stroke. We don't have great benefit. We don't know too much about coronary disease and heart attack, and metabolic syndrome. The data is not definitive. Part of the problem with this, now it likely offers benefit. CPAP likely offers benefit for these comorbidities. The problem is patients don't use them. And even in large clinical trials, getting patients to use CPAP for the majority of the night is very challenging. So that data is just simply not available to us. This bridges into the topic of CPAP compliance. Medicare and the other insurance companies define compliance as use for 4 hours per night, 5 days per week. And the compliance rate is all over the map when you look at the literature, generally somewhere between 25 and 80%. Most papers center around 40, 50%, but at least half of the patients are probably not going to be able to use CPAP. And those patients that get to somewhere in the neighborhood of an 80% compliance rate, that's measured soon after sleep apnea was diagnosed and they were prescribed CPAP, with frequent follow-up with either the physician, a physician extender like a nurse practitioner or a physician assistant, or the nursing and medical assistant staff at the particular office, and also very aggressive optimization of their mask design, meaning changing the masks around to find something that's as comfortable as possible. So a long-term compliance rate of 80% is probably unlikely. So we'll move into upper airway stimulation. We'll talk a little bit about the concept. There's 3 different devices that are in existence right now. The majority of the time we'll spend talking about the Inspire device, really only because that's where the data lies. So the concept of upper airway stimulation is to take advantage of the neuroanatomy and neurophysiology of the hypoglossal nerve. This is just a diagram of that hypoglossal nerve and the C1 branch heading off to the ANSA here. And you can see the extrinsic muscles of the tongue demonstrated here. So the styloglossus and hyoglossus, these are retrusors, meaning they pull the tongue backward. And the genioglossus here originates at the mandible and then inserts into the tongue itself, and that pulls the tongue forward. There's also intrinsic muscles of the tongue that we hope to take advantage of in order to stiffen and decrease the size of the tongue to some degree. So the idea of upper airway stimulation is to either pull the tongue out of the mouth and change the format or change the shape of the tongue to limit the airway obstruction behind the tongue, or, and we'll talk about this as we move on to the LivaNova device, take advantage of these intrinsic muscles and then the extrinsic muscles of the tongue to simply stiffen and change the shape of the tongue and have an impact on the pharyngeal walls. The other thing that we can see here is that there's a specific branching pattern, meaning we see takeoffs of nerve fibers innervating the retrusors, meaning the styloglossus and hyoglossus, early on, whereas the innervation to the genioglossus and the intrinsic muscle of the tongue is later. And this will be an important point when we start talking about the Inspire and Genio device. So, like I mentioned, there's 3 devices that exist right now. The Aurora 6000 is this is currently undergoing trials with, and this is that device here. This is undergoing FDA trials right now. And this was first developed by a company called IamThera, and that was just bought by LivaNova. So their trial was on hold for a period of time, and now it's ramping back up. This is the Genio device that's made by Nyxoah. This has 1 paper out, and that's was undergoing trials in Australia and France, and now they're starting to explore a trial in the United States as well. And then this is the Inspire device. So the Aurora 6000 device, the difference here is this is placed proximally on the nerve, meaning you don't select for the protrusor branches of the hypoglossal nerve. You're placing it more posterior, more proximal along the hypoglossal nerve. It has tonic stimulation, so there's not a respiratory sensor with this device. So there's tonic stimulation of the tongue, and within the cuff that wraps around the nerve, there's multiple different longitudinal electrodes. So you're trying to, when you titrate this device or optimize this device, you're trying to find the combination of electrodes that optimally stimulate the tongue to allow for some protrusion, but also elongation, flattening, stiffening of the tongue, and hopefully having some impact on the pharyngeal wall and patency of the airway at the level of the oropharynx and tongue base. This is the outcome paper from their initial study. So they had 43 patients in their initial study. This was published, I want to say 2017, 2018, so it's a couple years old, in laryngoscope. But you saw a baseline AHI of 35 and a treatment AHI of 25 at their 6-month visit. So you did see decrease in the apnea-hypopnea index and disease burden. This was statistically significant. Not sure if this is clinically significant, but this was the first trial. So anytime any of these products come out, there's always work to be done to optimize, and that's what this company is working toward now. And then you see ODI is oxygen desaturation index, and then some of the secondary endpoints or quality of life scores. ESS we'll see a lot throughout the course of the talk. This is Epworth Sleepiness Score. It's a objective assessment of daytime fatigue, and you do see significant improvement in the Epworth Sleepiness Score of the whole cohort here. So anything less than 9 or less than 10 is normal. Anything 10 or higher is abnormal. So their patients preoperatively went from an abnormal value to normalization. So they did see significant improvement in quality of life. This is the Genio device. So their first paper just came out, and a little bit different idea here or theory of how this is working. Again, no respiratory sensor. You have this horseshoe looking device that allows for bilateral stimulation of the hypoglossal nerve. They are taking advantage of the more distal branches, or those branches that are going to be innervating the genioglossus and the intrinsic tongue musculature. So a little bit different concept than the LivaNova device. And for placement of this, it's made through a submental incision between the mandible and the hyoid bone. And then dissection is carried out through the mylohyoid, through the geniohyoid to identify the genioglossus muscle. And you see those nerve fibers of the hypoglossal nerve sitting on top of the genioglossus muscle. Those distal branches are identified and dissected, and then these paddles here where the electrodes sit are then placed to stimulate those distal branches. Then everything's closed up. And this device, this is actually an adhesive pad, and this device we're able to program, and it communicates and charges the implanted device to allow for stimulation of those distal branches of the nerve at nighttime. Again, no respiratory sensor here, so you see more tonic stimulation. And this is their first paper this came out very recently in, I think it was the European Respiratory Journal. And you saw they had 22 patients included. I think they implanted or at least enrolled 27, and then 5 were lost to follow-up or excluded for various reasons. So just point out a couple main points here. You see significant decline in the apnea-hypopnea index. So they started with a population with moderate apnea, about 24 events an hour, and dropped to about 13, so able to get them into the mild category. And when we look at the p-value, that was significant. Also point out the Epworth Sleepiness Score, and FOSC is another functional outcome sleep questionnaire. So that's another assessment of daytime fatigue. So we see normalization of the Epworth score and significant improvement in the FOSC. So a higher FOSC is better. So now I'll move on to the Inspire device, and we'll spend the next probably 20 minutes or so talking about this, really purely because this is where the data lies. And it was FDA approved in 2014, so there's been a number of papers written on that. So this device has 3 implanted components: a stimulation lead, which we'll go through where that's placed on the nerve, an implantable pulse generator. So this is the computer and battery pack of the device. And this is the Aurora 6000 or the LevoNova device also had an IPG that's placed in a similar area on the chest. And then there's a respiratory sensing lead that's placed in between the internal and external intercostals. And the idea is that stimulation is linked to respiration to provide a reactive therapy to each respiration and a preventative therapy to limit airway obstruction with a respiration. After activation, the patient's given a remote, and they're going to use this to turn the device on every night. And then there's a physician programmer that we use to interrogate and also customize the device. So this picture back, so the thing about the different devices we've already talked about, the Aurora 6000 cuff is placed further back on the nerve, so back in this area. So you're not necessarily selecting out those protrusor branches of the tongue. You're including all branches, and the concept, like we said, is to try and customize the combination of electrodes that are stimulating the nerve so that we have optimal stiffening, protrusion of the tongue, and change in shape of the tongue, and then also hoping to open up that oropharyngeal airway. That Aurora device uses the concept of a muscular hydrostat, meaning you're not going to decrease the size of the structure or the tongue, but we can change its shape and move it out of the way to help to alleviate the obstruction. The Genio device, or the one that's developed by Nyxoah, that's placed up in here. So you see these genioglossus fibers through more of a submental incision, and those paddles are placed right up in here to stimulate both the protrusor muscles of the tongue, but also some of those intrinsic muscles as well. The Inspire device, so with this, you're trying to exclude these retrusor branches. So the nerve fibers that are traveling to the styloglossus and to the hyoglossus, and we're trying to place that electrode on the medial portion of the nerve, or the portion of the nerve that's going to be supplying the genioglossus, the geniohyoid, and also try and catch some of those transverse and vertical intrinsic muscles. We also try to include the C1 branch. That's a topic of debate around the country. Some people think that it will stiffen the strap muscles and then help to open up that hypopharyngeal airway to some degree. Some people think that by stiffening the strap muscles, it opens the mouth, allowing for the tongue to fall back further. Again, up for some debate. At our institution, we typically try to include it if it's anatomically feasible. So this is just an intra-op picture. This picture and the intra-op video that I have are courtesy of Clemens Heiser, who's in Germany. He does all these procedures with a microscope, so he's able to get some very nice picture and video. The quality is amazing. We do them with loops, so I use either 2.5 or 3.5 loops. I think at Pittsburgh, they don't use loops at all. I think Ryan Seuss just has Superman eyes that he's able to do this because he's very successful and very good at managing these patients. But most people around the country will use loops. So this is that medial branch and lateral branch that we're talking about. These medial branches are heading to those protruser muscles of the tongue that we're trying to include. And you see the C1 takeoff right here. Just to orient everyone, this is anterior, this is inferior, superior, and posterior. So you're seeing that proximal nerve coming in here and that branching pattern. And these lateral branches are the ones that are heading off to the styloglossus and hyoglossus. So we're going to end up trying to place our cuff right along here and exclude that branch right there. That's probably a late protrusor or late retrusor. So who's a good candidate for this? This is a bit of a moving target. Actually, just yesterday we heard that some of the insurers have now increased the BMI cutoff. So in general, the AHI candidacy is moderate to severe disease. The most insurance companies will say an AHI between 15 and 65. Blue Cross, at least in our area, has, as of yesterday, gotten rid of that upper limit. So anyone above 15 is now a candidate. BMI, I put this in gray and italicized because this is probably the biggest moving target. A BMI candidacy is below either 32 or 35, and that's a bit dependent on the insurer. Medicare, at least in our region, in our Novitas region, approves less than 35. Blue Cross and AmeriHealth, as of yesterday, approved less than 35. The rest approved less than 32. We tend to think that the lateral walls of the oropharynx are actually more of a predictor of lack of response than BMI, and also that complete concentric collapse that we'll talk about on the sleep endoscopy. You do see more lateral oropharyngeal obstruction in patients with a higher BMI, but it's not necessarily a rule. This only works for patients with obstructive sleep apnea. So patients need to have less than 25% central events on their sleep study. Obviously, by stimulating the tongue, we're not going to have an impact on central events, but we're able to move some of that anatomy out of the way and open up the airway. On a sleep endoscopy, and I'll show a couple videos here in a second, a pattern of collapse with a high probability of response. That's kind of a vague statement intentionally. The insurance companies will say lack of complete concentric collapse on drug-induced sleep endoscopy at the level of the velum. That stipulation is based on a paper that included 6 or 7 patients, so it's certainly not definitive. We're starting to think that it's more, like I mentioned earlier, more the lateral walls of the oropharynx collapsing inward that we're not able to have significant impact on, more so than the concentric collapse at the palate. So those lateral oropharyngeal walls or obstruction at the lateral oropharynx may be more telling or more predictive of lack of success than concentric collapse of the palate. With that being said, you will commonly see lateral oropharyngeal collapse in patients who have concentric collapse of the palate. Patients are unable to tolerate or have failed CPAP therapy, and then no medical conditions that would preclude implantation. So neuromuscular disease, Parkinson's being a common one, ALS being a common one that's talked about, and then also disease processes that would require routine MRI of the chest, abdomen, or pelvis, as this device does not have FDA approval for chest, abdomen, pelvis yet. It is approved for head, neck, and extremities. So this is a video of a sleep endoscopy of someone with that concentric collapse of the palate and lateral oropharyngeal obstruction. I'll just orient before we get started. So this is the palate. So this is, we're in the back of the nose. This is the soft palate. This is the posterior wall of the nasopharynx. And you have your eustachian tubes over here, and they're going to be out of view. But as we're looking down, you see a long vertical palate that has this concentric or almost funnel shape to it. And as we get down, you can see lots of obstruction or collapse of the lateral walls. So this is someone who's probably not going to do very well with a nerve implant, but we certainly do have other options, alternative treatment options to manage their sleep apnea. They're not relegated to CPAP for the rest of their life if it's something that they are not able to tolerate. And this is just another video, again, same orientation, but you're seeing this anterior posterior of the palate here. And if you see a line or almost a banana shape, and I'll go back and point that out, that's consistent with AP collapse. Here you're seeing a bit of an omega-shaped epiglottis. Tend to see this in anecdotally see this in patients who have severe apnea. The other things that we're seeing is lack of significant lateral oropharyngeal obstruction, but you are seeing a muscular tongue base that's falling backward as well. And just to go back a bit, when you see closure, you see this straight line or almost this this banana or arc here. That's fairly classic for lateral or AP collapse at the palate. So moving on to, or continue with our discussion about BMI, does BMI impact success? I'll say this again in moving forward, but it's probably less overall BMI and more the body shape or body habitus. So someone who has a very short but thick neck, probably not going to do very well with this device. But if that patient has the same BMI, but most of their weight is carried in their hips or their abdomen, and they have a relatively normal neck circumference, they may be a reasonable candidate. These are out of two of the ADHERE registry publications. The top one was from the ADHERE 500 publication, and the bottom one is the ADHERE 1000. That just means 500 patients and 1,000 patients. And what they saw when they looked at predictors of success and lack of success, one of the things was BMI. So that ADHERE 500 paper showed for every 1 unit increase in BMI, a 9% reduction in treatment success with upper airway stimulation. With the ADHERE 1000 paper, you saw for each decrease in BMI, a 8.5% increase odds of having more favorable AHI response. So overall, BMI probably does play a role. Our bias or our thought is that it's probably more body habitus than overall BMI. This was a paper we put out with some colleagues from Germany, and we looked at TJU as Thomas Jefferson University, TUM is Technical University of Munich, and that's where Clemens Heiser is. And so we compared our two cohorts a couple of years ago, and we saw very similar cohorts at baseline. And when we're looking at the outcomes, splitting these into a BMI less than 32 and greater than 32, we chose 32 because that was the cutoff in the United States at that time. We did see significant difference in BMI, significant difference in that, or closing on significant difference in that pre-op HI, with the higher BMI being more severe, but post-operatively, not a significant difference in the outcomes or the success rate. Success rate meaning the percentage of patients that are able to drop to an AHI less than 20 and a 50% improvement in that AHI. That's an old definition of success that's been used kind of classically throughout the sleep literature. So our argument was it was probably more body habitus, more so than overall BMI. And we need more study, or we need more information on neck circumference, on hip to waist ratio to make this a definitive statement. So again, neck circumference probably better predictor than overall BMI with truncal obesity and versus weight carried in the head and neck. So what about the surgery itself? So 3 incisions, one up here, about a finger breadth below the mandible, and try and center it over the lateral border of the hyoid, because you're trying to get down onto that digastric tendon. So you're trying to center that incision basically right over where the attachment or insertion of the digastric tendon into the hyoid is. You see an incision in the chest, and this is where that IPG is going to sit, and then an incision in along the, just anterior to the mid-axillary plane where that respiratory sensor is going to sit. This incision's probably, you can do it with about a 2.5 to 3.5 centimeter incision. It may need to be larger if that patient has a lot of subcu fat, or kind of depending on your exposure. A nerve that's tucked up high under the mandible is going to be harder to get to than one that's sitting right in your field. The IPG incision needs to be 4.5 centimeters because that's the size of the IPG, and this incision is generally 4 to 5 centimeters. So again, this is that picture from Clemens that I showed earlier, and we're trying to isolate those medial branches, or the branches going to the protrusor musculature and the C1 branch. And then this is a video. of placement of that cuff. So you see the ranine vein that's going to be overlying your nerve or in immediate relation to the nerve, and that's a good anatomic landmark to be able to identify the nerve. Early on, we were dividing that vein, as you see here. Now we, in most cases, feel like we're able to preserve it and just dissect it off the nerve and reflect it out of the way. So as he continues with his dissection here, you see that C1 branch and stimulation. And what I'll pause the video here for a second, because what I want you to see is contraction of the geniohyoid and some of the strap musculature. And as he works his way up, this is a NIM probe, that a bipolar NIM probe that we use as basically an intra-op EMG to be able to select which nerve branches to include and which nerve branches to exclude. And as you work your way up from inferior to superior, you're going to see contraction of that geniohyoid and some of the strap musculature, contraction of the genioglossus musculature, and then when he stimulates the exclusion branches, the hyoglossus, styoglossus musculature up in here. And again, this is anterior, inferior, posterior, superior. So you're able to see muscle contraction of that geniohyoid and straps. And then this is that main inclusion trunk, and you're starting to see contraction of that genioglossus muscle up in this area. And then as he's stimulating the exclusion branches, you're seeing stimulation of that hyoglossus muscle. So isolate out the branches to include in the cuff and then slide the cuff around. And then intra-op, we test the device to look for tongue motion. And what we're looking for is stiffening and protrusion of the tongue. You don't want to see the tongue pulling backward or laterally. That suggests that we've included a retrusor branch of the nerve. So this has good motion. And again, just endoscopy videos. So you see obstruction at the tongue base here. You're seeing the epiglottis in the distance and also the palate. And with stimulation, you're seeing contraction of that tongue base and opening up of the epiglottic airway, and also contraction of the palate. And this is what we're looking for in an optimal scenario. So post-operatively, so most patients we do as an outpatient. Patients who have significant comorbidity or are coming from a far distance, we may watch and put in the OBS unit for 23-hour observation, but almost everyone we've been able to do on an outpatient basis. Anticoagulation, we typically restart 24 hours later. So if they're on Plavix or Eliquis or another anticoagulant for cardiovascular disease, we'll restart the next day. We'll see them 1 week later for a wound check and take out stitches. 4 weeks after surgery, we activate the device, meaning we turn it on and we find the voltage that allows for gentle stimulation of the tongue. And the patient is given the remote, and then we're asking them to use it on a nightly basis and gradually increase the amount of stimulation until they notice symptomatic benefit, meaning improved sleep quality, improved snoring, and then also improvement in daytime fatigue. And then once they're optimized and symptoms are better and tolerating therapy, we will either get a titration polysomnogram in the sleep lab to further explore different voltage levels versus a home sleep study. And this is a topic of debate. During this COVID crisis, we've been doing home sleep studies, and it tends to work fine as long as those patients have been optimized. It requires a little bit more effort just to ensure that they're doing okay. So you only have to do one study, meaning communication through either telemedicine or phone calls. But the home sleep studies are a very viable treatment option, and some institutions are using this as their standard of care in terms of post-op assessment. Based on that sleep study, you make any adjustments that are needed. We have a lot of flexibility to change the configuration of the energy or the electricity that's delivered to the nerve, and also meaning which electrodes are stimulating as an anode or cathode, and what the rate and what the pulse width of that stimulation is, which can allow for different contraction patterns of the tongue and different sensation of stimulation. And then you make any adjustments that are needed ending that sleep study. Generally, we'll see patients after they're optimized at about the 6-month mark to a year mark, and we'll get a follow-up home sleep study at that point as well to confirm that we're doing okay. And this is from clematizer as well, but this is what you're seeing in the office with stimulation of the tongue. So you see stiffening and protrusion of the tongue. And then this is an endoscopy picture that looking at improvement of the airway at the level of the tongue base and also the. So what are the outcomes? So this was the original paper that that came out in 2014. This is that STAR trial that was published in the New England Journal. And what you saw, this had 126 patients in it initially, and you saw a pre-op AHI of 31 drop to 7 or 7.5 at that post-op visit 1 year later, and a similar drop in the ODI or oxygen desaturation index. And these are our post-op. This is the post-op data as this cohort was followed through 5 years. So there was publications at the 12-month mark, 18th month mark, 36, 24, and 36, 48, and 60-month marks. And sleep studies were done at 12, 36, and 60. And you see improvement in that AHI and maintenance of that AHI, and this is just shown graphically. So you see that significant drop in AHI and maintenance of improvement. The Epworth Sleepiness Score, again, dropped from a abnormal level to normal, and you're able to maintain that with continued use. This is that FOSS score, so you see improvement in that FOSS score and maintenance, and then response rate is they're measuring here as well. So this is throughout that that whole 5-year time course and summarizing these multiple publications. This is data from our institution, and we put a paper out with Ryan Seuss at the University of Pittsburgh, and we basically compared our outcomes to each other, but also put a large group together. And this is one of the first clinical, or I should say, outside of industry sponsored papers that were out there. So when we compare the two groups, there's about 75 in each, and you see a very similar pre-op disease burden. And post-operatively, we see very similar reduction in the AHI and also normalization of the Epworth score at both places. And again, comparing the outcomes between the two institutions graphically, surgical success we define as improvement in the AHI to a value less than 20 and a 50% drop. So very similar there. And then the percentage of patients reaching a postoperative AHI less than 15, 10, and 5 are shown here. And then just the numbers. And then when we compare the two cohorts, you see a significant reduction in AHI, improvement in the oxygen desaturation nadir. So this is how low their oxygen level drops, and then also improvement in the Epworth score. There have been papers comparing upper airway stimulation to more traditional sleep surgery with UPPP and TORS based tongue reduction. And this is one of those papers. This is out of Cleveland Clinic. Alan Kaminsky is there and does the majority of these cases. And they took 20 patients who were undergoing UPPP and compared it to 20 patients who underwent upper airway stimulation. So you see that the upper airway stimulation patients are older, and that may be because early on Medicare was covering it versus more aggressive reconstructive and ablative surgery to the airway isn't necessarily as an acceptable option for an older population. These are the two thoughts as to why that might be. The pre-op AHI very similar, so disease burden very similar between the two groups. And post-operatively, you see a post-op AHI of 28 in the UPPP group and 4.5 in the upper airway stimulation group. Typically, you will see, looking at the literature for UPPP, a 30 to 35, maybe 40% reduction in the AHI with that surgery done in isolation. So this is pretty consistent there with those outcomes, but you do see a significant improvement. This is a bit of an apples to oranges comparison, and I'll show one of our papers, which is similar, as the UPPP is a surgery designed to limit obstruction at the lateral walls of the oropharynx and also at the level of the palate, where upper airway stimulation, you're triggering tongue-based obstruction and then hopefully moving that palate out of the way as well with the anchorage through the genioglossus muscle. This is a paper we put out a couple of years ago or a year ago, again, comparing patients undergoing expansion sphincter pharyngoplasty. This is I'll call it an updated variant of UPPP. So it's more a reconstructive procedure where we're utilizing the palatopharyngeus muscle to help to support the lateral walls of the oropharynx. And we're reorienting that palatopharyngeus muscle in a goal of supporting the lateral walls of the oropharynx and also hoping to open up the level of the velum as well. But again, we're comparing upper airway stim patients to expansion sphincter pharyngoplasty patients. Similar preoperative findings as Alan Kaminsky's group with the stim patients being older. And postoperatively, we see improved results where our pre-op AHI in the ESP group was about 27 and about 37 in the STEM population. And we see a drop to 13 and 7 in the respective groups. We do see normalization of the Epworth scores in both cohorts. There's been 2 papers out on TORS, and one from the University of Pennsylvania and Erica Thaler, and one from us. This is just our paper, and again, you see improvement in the post-op AHI outcomes with the upper airway stim group compared to TORS. This is a bit less of an apples to oranges comparison, as I think it was about 80% of the TORS group had palate surgery at some point in time as well. So this group, majority of this group did have a multi-level approach to management of their apnea. The interesting thing that we included here was the TORS group on average went home a day to 2 post-op, whereas all of our STIM patients went home, and there was a readmission rate of about 16% in the TORS group for various things like dehydration and pain. There was no major bleeds or anything like that. That was what we included in the complication group. So I'll finish up with some of the ADHERE data and then open it up to any questions. So the ADHERE registry is a prospective and retrospective database through a number of institutions, both in the US and internationally. And what we're trying to collect is preoperative demographic and disease severity data, and then postoperatively looking to see what the outcomes were from a objective sleep study standpoint, more subjective quality of life measures, but then also tracking complications as well. So far, there's been 3 papers put out. This paper, where Erica Thaler from Penn was the lead author, had 1,100 patients, and we saw significant reduction in the AHI. So we saw pre-op from about 33 down to about 6 at that 6-month visit, and about 9 at that 12-month visit, or that follow-up visit. Some of these 6-month values were probably titration studies. So probably not the titration studies. We don't think are the best assessment of postoperative outcomes, because it's really only a small time period that you're assessing their sleep. You might get a value for 30 to 60 minutes from the course of the night, whereas some of these 12-month studies, or more of these 12-month studies, were probably home sleep studies assessing full night outcomes. And with this paper, they also looked at predictors of success. So found that gender and BMI were predictors of success, where female gender was statistically significant, or was a significant predictor of having a more favorable outcome. And like we mentioned earlier, BMI at baseline, so a lower BMI was also predictive of a higher success rate. One of the interesting things to talk about when we're talking about either surgery or upper airway stimulation is usage of the device. So traditional sleep surgery, like the UPPP, TORS, MMA, genioglossus advancement, hyoid myotomy and advanced tongue-based sutures, so these are used for 100% of the night. Upper airway stimulation, you see various compliance rates or usage rates, but so the paper we put out with the University of Pittsburgh group, our usage was 6.3 hours measured at 9 months post-op. This original ADHERE paper, or I'm sorry, this was the ADHERE 500 paper, their usage was 6.2 hours at 12 months. And then the most recent ADHERE paper showed a usage rate of 5.6 hours per night at 12 months. When we compare this to CPAP, it's significantly improved. Most of the data with CPAP show somewhere between a 3 to 4.5 hour usage per night, whereas I would argue that you're seeing patients use upper airway stimulation for the majority of their total sleep time, or a significantly higher proportion of their total sleep time. Another topic that we can talk about some other day is something called mean disease alleviation. And this is the idea that you're factoring both usage of the intervention with the amount of disease reduction. So although CPAP may provide more reduction in AHI, your usage is much less. So overall, your benefit may be that of some of these other surgical interventions, even though you're not seeing as drastic a reduction in the AHI. So lastly, we'll talk about complications. This is a table from that last ADHERE paper. You see a very, very low complication rate. So tongue weakness at their final visit. So at that 1 year visit, there was no residual tongue weakness. There was a few episodes or a few events of paresis, but this was 3 out of 1,100. Swallowing, one person had swallowing complaints at a year, and I'll show some data about swallowing. There was 2 early infections, but no late infections, and most people did very well when it related to just tolerance of the device and then other complications, but no significant bleeding, very minimal complication rates. So a very low complication rate when looking at this procedure as a whole. This was a paper again from Cleveland, looking at swallowing and voice outcomes afterward. So they had, I think this had 14 patients in it, and they did a pre and post-op EAT-10. So this is a 10-question swallowing questionnaire, and VHI, which is a voice handicap index. And you saw no residual swallowing problems at that 6-month post-op. And again, no residual voice issues, with the exception of that one patient at 6 months. So suggested that even through stimulating the tongue, you're not seeing post-op issues with speech and swallowing. This was a paper we put out a couple of years ago that, again, we had included 33 patients, and they underwent an E10 questionnaire pre-op and then at least 3 months after their activation. So 4 months post-op, because that activation visit is at 1 month post-op. And that E10 was no difference. So repetitive stimulation of the tongue does not cause dysphagia, or unlikely to cause dysphagia. So in summary, upper airway stimulation, in the right patients, it's very effective and it's a safe surgery to do. Patient selection is the key. So finding the right anatomy and the right patient to implant is your biggest predictor of success. And we've got new technologies that are coming out and undergoing FDA trials right now. So we'll have more options to come. So hopefully we'll be able to customize patient care even more. So happy to answer any questions that have popped up. I'll stop sharing here to see. Oh, my battery's almost there. Looks like there was one Q&A. So the first question is, what do we do with persistent clinically significant disease afterward? So it's different institutions have different approaches. First, we'll generally bring the patients into the office and do an awake endoscopy. And we have a lot of ability to customize how the energy is delivered to the nerve through the way that this device is constructed and engineered. So that cuff has 3 electrodes on it, and each electrode can have a positive charge, a negative charge, or be off. So you have 5 different combinations that you can do, and it allows for it allows for different delivery of energy and a change in the electric field surrounding that nerve, and that's going to then cause a different stimulation pattern, and different stiffening of the tongue that can have an impact. So an awake endoscopy is where the patient comes into the office. We use an MPL to go through these different combinations and stimulate the tongue, and in the awake state, but also we put them in a recumbent position, see how much contraction of the tongue and coupling at the palate can occur. Our next step is to do a drug-induced sleep endoscopy with device titration. And we're doing the same thing, but with the patient asleep and on their back. And generally, this is effective in finding a combination or a stimulation setting that's going to allow for optimal contraction of the tongue and opening of the airway and disease alleviation. The other thing we can do is add a body position device. So it's just simply something that makes the patient sleep on their side, so the tongue isn't having to fight against gravity and give us some added benefit. Right early on, we had a lot of difficulty getting it approved, as most of the insurance companies had this categorized as experimental. We put a paper out a while ago that compared the Medicare patients, because Medicare in our region, in the Novitas region, had a positive coverage statement, whereas early on the private insurers considered this experimental, and we were going through multiple rounds of appeals and eventually getting it covered. And it was about a 6-month difference in time from sleep endoscopy to time of surgery, so significant delay in delivery of care. Now, most insurers have at least in our area, have a positive coverage statement. The policies are changing. Like I said yesterday, Blue Cross and AmeriHealth changed their policies with regard to the upper limit of AHI and BMI. Medicare was the first to change their BMI. So right now, it doesn't seem to be as much of an issue, and we're very successful getting it covered. The second question, what causes palate stiffening? So it's not necessarily stiffening, but looking more to see the palate come forward a bit. And when you're doing these awake endoscopies, what you tend to see is opening of the lateral velopharyngeal port, specifically on the side that we implanted. And we almost always do this on the right-hand side, just out of protocol. We can do it on the left, but because cardiac devices are put on the left side to limit confusion, we put them on the right. And what's happening is early on, we stuck EMG electrodes into the palatal-glossus muscle to see if there was some cross stimulation, and we didn't see any muscle firing, but we think it works as a kind of a static anchor. So as that tongue stiffens and moves forward, it pulls on that palatal-glossus to help to open that up. And what we're trying to get is that multi-level response at the level of the palate or velum and tongue base. What we haven't found is a good way to get lateral oropharyngeal wall stiffening. And this is kind of where our limitation is right now. Next question is, what is the best way to get experience certified with devices, if not in residency? So I know we have folks that come and observe and spend time with us, and some of the other sleep surgeons around the country do as well. And right now, Inspire is the only FDA approved device. So they have a cadaver lab that if they're trying to set up a program at a certain institution or with a certain surgeon, part of that process of getting certified is to go to that cadaver lab and do cadaveric dissections. Let's see. And last question, any pediatric patients? So we have not. There is a current trial going on right now that's Chris Hartnick at one of the Harvard hospitals or in Boston is heading up, and that is specifically related to pediatric patients with Down syndrome. So again, in select patients, and patient selection is key, the Down syndrome patients with Down syndrome have seen significant improvement in their disease severity with the use of this device. But that's a trial that's in the process of closing, I believe, because the company is going toward FDA approval for that indication, pediatric patient with Down syndrome. And then that will be moving out toward, I guess, post-market or post-approval studies at other sites. So currently we have not done any with pediatric patients as I'm at an adult hospital. Any other questions? All right, well, thank you everyone very much.
Thank you very much. Appreciate it.
Thanks for the opportunity. Hope everyone
Yeah,
stays
maybe
safe.
contacting you for some more sleep lectures in the future. This is great.
Happy to. We've got our residents, I think, are tired of it because we have two of us at our shop who do this. So
Ours are begging, so we'll reach out.
more than happy to.
Great, thanks. All right, take care.
Have a good day.